every household, every CHP is given 100 households. They go there well equipped in terms of the gadgets they have. Number one, they have the pressure machine. They can know your pressure. They can advise you if your pressure is high, that please you need medical attention. They can take your blood sugar. They can confirm what is your blood sugar at that particular time. They can advise you. They can do what's called prevention. From there, if you have a case and then you are referred, we are trying to change also the delivery system of our healthcare. For a long time, and if you ask Governor Sayang, most of the patients used to go to their level 5 hospital. Whether you have headache, minor ailments, you go to that level. We are saying do not burden the referral hospital. Start from level 2, where your minor ailments are handled and you don't pay anything as long as you're registered. And this time, that level 2 hospital is also going to benefit because it is capitation based on the number of people registered in the county. So the more you register your people, the more revenue your facility gets, because they will get each and every person who is sick will visit that facility. But this time, when you visit, it is not manual records. We can tell you your health center, how many people visited that health center.
But even as you say all this, you cannot ignore that people have said there have been delays when they're trying to register, when they're trying to access services. Private hospitals suspended services on account of the pending bills. There have been issues.
Okay, I agree with you, Olive. The issues when we started initially, of course, there were system challenges initially, but that was rectified. We were able to expand because we realized so many people were registering at a go. So we were able to expand the storage capacity so that many people are now able to be accommodated during the registration period. So it happens with the system. The private facilities, those who are saying that they did not refuse to offer services because SHA was not paid. You ask them if SHA is not paid. We do not have any pending bill for more than 30 days.
Under SHA?
Right now, yeah, under SHA.
Okay.
What they are complaining about is the outstanding amount that the defunct NHIF owed them. And we asked them how much. We got to know exactly how much. Right now, we've done the additions. It comes to about 30 billion. But if you ask them when they were under NHIF, they were being paid for a claim which is 6 months and beyond. They were not current. Right now, what we are paying is within the 30 days. We have also amended the law that under the Social Health Authority, no claim shall go beyond 90 days.
Or beyond 90 days.
All claims should be settled within 90 days. So as we are speaking now, we are very confident, comfortable that we are paying our service providers.
But the target, as I understand it, is by the 14th of every month.
Now the target, the CS has said that the target is to make sure that those who are contributing by 9th, then within the 5 or 6 days, we should also have paid the facilities. So by the 15th, the facilities should receive their money.
I see the governor is keen to chip in at this point.
Yes.
I think we just want to be a bit practical. On our side, there have been delays, and the delays for payment of our claims has gone to about 2 to 3 months. However, for us, this is generally an improvement because under NHIF, we had a bigger problem. So we still think that there is work for SHA and the national team to ensure that they are able to meet those deadlines. Mm-hmm. Of course, the bigger cry by other facilities is that previously, somehow, and it's important for us, and the reason why I keep on referring to where we have come from, is that we want to ensure, to be clear that this is a better system than where we've come from. Some of those complaining had their claims being paid timely because the system favored them. The the public facilities were greatly disadvantaged in terms of payment. We have pending bills, agreed, just like private facilities had their pending bills. We still have those claims ourselves. We have not been paid. We hope that they can be able to clear that pending bill. But going forward, if we can ensure that the claims are paid timely, that will ensure that our facilities have resources to be able to plow back. And in any case, we now have facility improvement fund. meaning that the resources do not just come to the county government of Nandi at the county level. They go directly to the facilities. That avails resources for purposes of ensuring that there is running and operations of the facilities.
Right. Before tufungue mjadala, we have an economic advisor here. So having listened to the two gentlemen, what's your response?
Let me say this. One, on the SHA, I didn't want to emphasize what the PS has said, that the law requires that we pay within 90 days. Nevertheless, regardless of that position, the president has directed that all claims must be paid within 30 days, okay? So as we speak, we have got two levels of claims. The levels of Social Health Insurance Fund, SHIF, and the primary health care. As we speak, all February claims, all the claims that have got no question for the month of February have been paid. As we speak, we are currently processing the March payments. And the CS Aden Duale yesterday stated that by 14th of every month, not just the shift, the big claims, but even the primary health care for that Kabiet, level 3 hospital will be able to get their money the same way Aga Khan is getting. Because as a governor, he said it's right. The system was rigged in the favor of the rich. Now we are trying to rig it in favor of the poor. And that is a fact that, we want really to rejig this particular equation, that even that facility in Kabiet is as important as Aga Khan. And let me tell you, Olive, I know, and I want that to be challenged even by private hospitals who are here. Let any private facility which is here say that they have got any claim for February that has got no question. We have cleared that. Governor to tell me that primary health care for February for any facility is not received. That's how we are sure of ourselves. And we are going to continue with that. But on the flip side, let's look at NHIF. The 30 billion which PS Kimtai is talking about, it's very important to say that there are claims within that 30 billion dating back to 2016. 8 years. I've said SHA is 6 months. We are paying by 14th of every month. We are being harassed for debts that were accumulated from 2016. 9 years. If NHIF was such a good piece of bread, how are they accumulating debts for 9 years?
All right, Swachet Fungwe, let's open up the floor and we'll come back with a couple more questions. Do you have something to add?
Just one point to mention on these claims. One of the challenges that public institutions have is actually the gadgets to carry out the claims. The billing and the claiming is an issue. Most of the private facilities, of course, they have the ICT infrastructure ready and operational. We are hoping that we will receive our gadgets, because part of the delay in making those claims is that if the facilities do not have internet, they do not have the gadgets, they do not have connected electricity connected to those facilities, and therefore there is still some bit of work that should be done. And I know under this whole program, there was a team, a consortium that is supposed to deal with the entire infrastructure around ICT, gadgets, and connectivity. That is critical.
Just jump in there, Governor. That is the unseen benefit of this project, that every level 2 and level 3 facility is getting devices, every health practitioner, with internet inbuilt within those devices. Every
Ash must have been abrupt.
Download Clover. Order food, groceries, flowers, and diapers with electronics or anything you want. We'll deliver in minutes. Okay, I publish you up on a receipt one.
It just hung. Giza. Ilihang kwanza alafu giza. Ati? Oh, support. So when we come back, we're just trying to sort it out. The lights went off, so we're just restarting our machines. Yeah, you can have your questions ready, okay? This is your time now. It's your time to shine. Eh? I'm sure they'll make good. They'll make good. Kara said she'll add for you time. So sorry about this. Okay. All right, we're coming back. Scene circumstances, but if you're just joining us, we're coming to you live from Nandi County, more specifically Baraton Town, in which it is located, the University of Eastern Africa, Baraton, which is hosting a town hall this afternoon on TaifaCare for 2 days. There has been a mass registration drive here driven by Moses Kuria, Senior Economic Advisor, Council of Advisors, Economic Council of Advisors. We've also had the Governor, Nandi County, by his side, giving feedback and proposals as well in real time. And the PS Mining and Medical Services, at least for now, Hari Kim Tai, we're opening the floor to the audience now. And this is your time to tell us how things really are on the ground, because that is part of what this is aimed to achieve. So if anybody has a question, feedback, especially those who are directly concerned, the stakeholders, private hospitals, faith-based, those who are getting the services. I see a gentleman here in a black shirt. If you can just pass the mic back to him, just pass it back to him. You can introduce yourself and then make your contribution.
Okay, thank you very much. I'm Tevin Otieno Akama.
Sorry, I didn't catch that.
I'm Tevin
Tevin Otieno?
Akama.
Okay.
Thank you very much for coming to Baraton. I see the closest friend to our able president here, and this is my question. Now that you have introduced SHA, SHIF, and TaifaCare, how may it be more influensive to the student who have a zero income now that you have introduced a new funding model that doesn't give us any upkeep money from the old model system? How can we start this SHA as a zero income person now that everything has gone lost? And then you need to know that after this, after coming out of this institution, many of us will go out there to start families. Now we may not need to depend on our parents to enroll us in that SHA or SHIF or TaifaCare. So how may we get involved, or may the SHA and SHIF give us affordable health care for us who have a zero income? Thank you.
All right, let's take at least two more questions. I see two ladies right there.
Thank you, Mr. Governor and the team. I am Tabitha Garang from South Sudan. This shows Baraton is an international institution. Now through Nandi County, I am proudly, and I can say, Kenya is a country that embraces human beings regardless of their races, their identity. Now as a foreigner, how do I benefit from this?
All right, you can just pass the mic behind. There's a lady in the white shirt. You can go ahead, introduce yourself.
Okay, thank you very much. My name is Michelle Jepchumba.
Michelle?
Jepchumba.
Okay.
I have one question. Now that the SHA is not covering the private sector, how is the government going to implement the SHA in the private sector? Because most of us prefer going to hospitals in the private sector. Thank you.
All right, that's Michelle is being honest. All right, can we take okay, one more. There's the gentleman in the glasses.
Okay. My name is Emmanuel Kizito. I have a question. So whom are we to trust? The political perpetrators, the closest friend to the president, or the patients who are complaining that SHA is not helping them?
Okay, who are we to trust? Very good questions. I see. Mumeanza kuchangamka, naona mumeanza kuchangamka. Let's take those ones first. Nimeona. We'll come back. We'll take another round of questions. And let's start with that question by Kizito. Kizito has asked, who are we to trust?
Actually, I don't want to trust politicians because I've listened to them in Nairobi. And Olive, I came here to listen to those patients. Yesterday, I did 8 stops. It came to a point I offered cash money for anybody who will come with an actual problem. Only one lady in a place called Mosoriot told me about problems of people trying to access outpatient services in our level 4s and level 5s. Yeah? And I agree that we have got a policy issue there. Tomorrow we have got this health caucus where the PS and the team will be able to address that particular issue. Somebody who is used to going to Kapsabet level 5. As you know, we are trying to decongest our level 4 and level 5s by empowering our dispensaries, our health clinics, so that by the time you are referred to level 5 and level 4, level 5, and MTRH level 6, that must be a very serious case. So far, that is the only case which I have seen from those people called patients whom I trust more than politicians. I am asking, where are these patients?
But what about those who say these primary health facilities are understaffed, are under-equipped, they don't have medicine?
Olive, that is why we have opened up a call center, 147. Every day I'm checking on the issues on that call center. You know, there is something in law which says that he who alleges must prove it. So we are here. We are saying, where are the patients? My friend, maybe we give him some time off. Go and bring me 10. I solve them now.
Okay. Governor, what is the situation with those levels, those facilities? Because healthcare is an evolved function.
Yeah.
Yeah.
Of course, one of the things that we must appreciate is that there are challenges within the healthcare system. And that is why we have this new model that seeks to address each and every challenge that that has been witnessed within the system. One, I agree, in terms of standardization of services to be offered at which level of government. That must be addressed, because for what Kuria is saying, in terms of for you to go to level 5 or level 6 only under referral cases, it presupposes that at the primary level, at the dispensary, you have received whatever cadre of health provision or service that you need to receive at that level. As we speak right now, we are not yet there. And that is why we are, and why are we not there? The challenge of the resource envelope. And that is why once you have this complete rollout of SHA that ensures that resources are available at each level, so that then at the point of dispensary, of course at the level of primary one, we have CHPs. Now they are operational, they are working, they are going house to house, they are addressing the issues at their level. The next level is level 2, where you have dispensaries. As we continue to get the claims and the resources, and as county governments continue to invest in that level 2 facilities, then you ensure that all the workers that are supposed to be available at the level 2 are available, and that then the service can be provided at that level. It then goes on all the way to level 3, and it goes to level 4. What we are only telling the national government, and that is why this issue of outpatient arises, is that let us implement this program progressively. You don't make the assumption that all the level 1s, the level 1s are okay because these are the CHPs, that all level 2s and all level 3s are already there. I have given examples that some dispensaries don't even have electricity. Some of them do not have the gadgets. Most health centers do not have internet. This rollout is supposed to ensure that all dispensaries, all health centers have those gadgets, and that then you can be able to stagger that the implementation of UAC. So we must be practical, and I think that is what we are saying as counties, that let us be practical in the implementation of this program.
Yeah. And maybe that's why Michelle is saying she prefers going to private health facilities, because they have all the facilities she needs. But P.S. Kim Tai, I was listening to Tevin, and Tevin was even confused. He said SHA, SHIF, TaifaCare. He's not even sure what it is called. Kidogo aseme shafashi.
I think we've heard the chorus. Now Kenyans know that under the Social Health Authority, we're delivering TaifaCare. That is the name of our social medical cover that we are doing as a nation. It's called TaifaCare. The SHA is Social Health Authority. That is the agency that handles all matters related to this TaifaCare. SHIF is Social Health Insurance Fund, meaning that if you pay your premium, you've registered and paid your premiums, then that will go to a social health insurance fund. That's why the word SHIF comes in. The SHI is the Social Health Insurance Act. That's why we say SHI, because it is now that is the act that anchors all this TaifaCare into what we are delivering. So you should not get confused, and that's why we've said it is TaifaCare, meaning we care for our nation in English. And let me come to you now, the question you asked.
Students?
That you are a student. If you go to the act and the regulation, it says a dependent who is still a student over 18 years and below 25 years, who proves that he or she is still under the parents, being educated and in school, then you are a dependent of your parent. When now you leave university, you have cleared, then you become a Kenyan who is looking for income. Either you will be employed, and if you're employed, 2.75% will be deducted from your monthly income. If you are not employed, then you will go through what's called a means testing to ascertain what income are you involved in, what kind of income do you earn. Then out of that, again, you will be given a premium that you are supposed to pay, which is the means testing tool will have ascertained what kind of activities are you engaged in. So basically, if you are not able to pay anything, again, you are not left out, because Then you become what's called, the government will pay for you because you are an indigent, meaning you are not able to earn any income, and therefore it is a responsibility of either national government or the county government to take care of you, or if there are some organizations who also want to pay for a certain community. So let me come to
Foreigners?
Let me come to
Tabitha,
who says, I want the private. That is your choice. If you want private.
Oh, no, that's Michelle. Tabitha asked about foreigners, right?
Let me just answer the one for Michelle first. You see, now we've given you a choice. You want to go to a faith-based, you want to go to a private, you want to go to a government, as long as they are all in panel and contracted by Social Health Authority through the regulator, that's KMBDC, who then recommends that this offers these particular services, and therefore that facility is in panel. The claims or the treatment, the benefit package is the same, irrespective of whether private, faith-based, or county government, or that's national government. National government, we are talking about referral facilities. Let me come to, Tabitha? A foreigner. You're also eligible because you have you're supposed to register and prove that indeed, like for example, you're a student here, that you are undertaking your studies, so it is the responsibility of your parents to pay, including paying for your social health authority while you are here. For foreigners who are traveling again, as tourists, we have what's called the inbound travel medical cover. Those ones will be covered separately. They will pay when they are entering the country. So it caters for everybody, those who are foreign, those who are resident here, even the ones who are refugees. We have now registering them using their alien cards, so it covers for everyone.
All right. Can we take a couple more questions?
That under NHIF, we had around 15,000 hospitals or facilities. Under SHA, we have 9,000. 6,000 facilities, out of their own free will, they have decided they don't want to join the bandwagon. And because we are a democratic country, there's nothing much we can do about those ones. But for the private facilities that are participating, they are empaneled and they are contracted. We are not discriminating. If you are paid, for example, for shift, you go and get inpatient services from a private hospital with the same cover you can get in public hospitals. It is what I say in Nairobi. You have a meal at Serena for the price of Kibanda. Hakuna shida. We are treating all of them in the same way. However, there are some private facilities, even though we are not discriminating, especially on primary health care, they have refused to join the bandwagon. And for those ones is where I'm challenging Governor Sang. As they refuse, ni bahati yako, because the money that is there will only be shared by public facilities. Because if somebody refuses, it is their right to refuse. And also for the gentleman there, the student, the zero income, the dependents, if you are under your parent and you are below the age of PS, I believe it's 25 years, and that gentleman doesn't look like he's over 25. And you don't need to have an income, because when your parent registers you and you are added as a dependent, you are automatically covered with your zero income. That is why today, here at Baraton University, we were registering the students in the morning from the registration of their parents. That is why on Friday, we are actually closing all the private and public schools in Nandi County and in Marakwet County to have the students there so that they are all equally covered.
Actually, I received a message. Kindly inform Olive that all students who haven't been enrolled on SHA, the exercise is ongoing here and after this show. Let's take another round of questions. We'll start on this side. There was, you had a question you wanted to ask. Where's the mic? Oh, okay, you can ask your question. If you have the mic, ask your question and then pass it to the front. Who has the mic here? Oh, he had the mic. No, let him ask. You had a question. The CHP worker. Ulikuwa na swali? Huna swali? Okay, sawa.
Thank you so much. and I want to appreciate the panelists. My name is Pastor Eliaza Kogei. I represent the faith-based facilities within Nandi County. And I want to thank what has been mentioned. I think the panelists have really tried to answer the questions that we had when we came here. In Nandi County, we have several faith-based facilities for different churches within, or faith within this county, ranging from my own Seventh-day Adventist Church, the Catholic, the AIC, the others from ACK, and even Pentecostals, and even the Muslims. And what was very common, and I want to admit that for sure we appreciate the government on the initiative of this TaifaCare. The reason is what has been mentioned by the panelists. Before, and even today, some of many facilities which are faith-based were almost at closure, in fact, because of the huge pending bills from the other NHIF. And I think because we transitioned to this new one, initially there was a huge challenge on the pending bills, the claims actually. But I want to appreciate that today some already have managed to receive their claims. And I think moving forward, as what has been mentioned, if actually we can be able to be faithful to ensure as a government 90 days, that kind of arrangement, we will be able to see that facility working very well. I want to say that most of the questions were raised by CHAC or representatives of CHAC, and I think it has been answered on the way it has been answered here today. The main thing that has been affecting the faith-based is the question of the claims. Okay. And because there's no any other source, majorly, that has been the main source. You know, as soon as we do that, we get what to be able to pay those who are working in the facility.
You keep,
but
you keep your doors open.
Yeah, sure.
All right.
Yeah, thank you so much.
If you could just, thank you so much. Makofi yake. If you could just pass the mic to the lady who has matching hair with me.
Thank you. My name is Dorcas Cheruyot. My question on the same is to check if the SHA or the SHIF can also accommodate maybe the very, very old people you find in the community. Sometimes they are those very, very old. And I was thinking this could also accommodate them for the medical checkup, maybe once a year. Can that work?
All right. I'll ask the peers to take that one. Let's take a few questions from this side. Go ahead.
I have the mic. Thank you. Ladies and gentlemen, all protocols observed. My name is Dr. Kamonzi Mulei. I represent the Union KMPDU as a branch secretary in North Rift. Thank you for the invitation. We are really delighted to be here. Just assure that we don't have to always be at loggerheads. Sometimes we can have a roundtable discussion into our issues and find amicable solutions to what is facing us. I will be very brief and allow me to just point and highlight a few reasons why NHIF failed, and we know the reasons. And it was all about funding. NHIF had the EduAfia, had the Linda Mama, and all those other schemes where the national government was supposed to fund. And you know, we have to say issues as they are. As we talk, the issue that affected NHIF is likely going to affect SHA if it is not checked. Because we are all talking about funding. You know, we have the 7 key issues in health. But of course, the main issue is funding. Because right now, a nation with a population of 30 million, 60 million, close to 60 million, we are talking about half of the population, less than a half being able to pay. Like more than 60% actually in the informal sector. They don't have a pay slip, they don't have a salary, they have to pay from their pockets. what is going to happen if we are giving 3 to 4% of our budget to health? We really need to have this conversation. And the earlier we do this, the better for the health of this country, because we are running a social scheme whereby people are supposed to contribute. The national treasury is supposed to cover the two aspects of that. But then we don't know. There has been a problem, and I have to tell you that. Because if you allow the Abuja declaration to really take effect and we give like 15% of our budget to health, then some of these problems will not be there. We'll be able to cushion the elderly, the people who cannot be able to pay for themselves, and the rest of the disadvantaged communities. So we really need to have a look at that. And then also...
Dr. I'll ask you to be concise so that I can also allow other people to contribute.
Thank you.
Yes.
The other issue is the issue of the referral systems. I think this one has to be, I know it's a policy, yes, but as you look at the issues that has affected SHA, we have to look at the issue of referral system, because you're denying that patient the emergency care where they're supposed to be taken care of. For instance, if I have a maternity issue, if I have an ailment, and I'm near to MTRH, and now you're telling me, for you to be seen in MTRH, you have to be referred either from Wasindishu County Referral Hospital or Kapsabet. So does it mean I have to go back to that facility so that I can be referred back for me to be able to access the services in that facility? So let's look at those issues.
Funding,
and even
referral
lastly,
system.
Funding, the referral system, the policy, people really need to look at that document again. Of course, it's law, but it can actually be made much, much better. Initially, we were saying that SHA will not work, but now we have to make it work. Lastly...
No, that was the last one. That was the last one. Pass on the mic to the gentleman. We'll come to you, but first the young man, and then we'll come to the gentleman in the glasses, with the glasses.
Thank you very much. My name is Colin Skibet from the Agye community who live in the remotest part of this country. So the question that I have today is, what is the government doing so as to create awareness in those communities?
Marginalized communities.
Yeah.
All right, thank you. The gentleman with the glasses.
Thank you so much. My name is Wilson Oroni. I come from Akili Foundation in Itigo. We are a private institution dealing with the rehabilitation of people who've been affected by drugs and alcohol. We have patients who come and register with us, and they keep asking us questions. And right now, we are in the process of registering with SHA, and some of our students or clients who come may also be registered with SHA. The question they ask is, what will SHA specifically cover? Is it the institutional fees? Is it medical expenses? Or is it bed or accommodation?
That's a very good question. Will the lady in the glasses just in front of him, and then we'll have the gentleman with the white shirt. Sijawasahau. The next round will start here again, yeah? All right.
I'm Susan Biwot, a nurse. Just a question of what is the new version of Linda Mama that we had in NHIF that is going to take care of the maternal neonatal health issues? Thank you.
All right. Thank you very much.
I'm Festus from Chamber of Commerce. I got two questions. One.
Sorry, I didn't catch your name?
Festus Kikoich from Chamber of Commerce.
Okay.
Two questions. One, is it possible to cap the referral issue? Is it possible that we open a dispensary inside a referral hospital? Because some patients believe they will get healed in referral hospitals. Two is the question of the mortalities of getting the member contribution. You find a husband and a wife, both of them jobless. Then the husband is told you have to pay 1,000. The wife is told you pay 400. How fair is the mortality that is used to determine the member contribution? Thank you.
All right, let's take those questions first. Do you want to start from Festus, moving back?
I think you assist us by ensuring we answer all questions.
All right, so let's start with Festus's question on member contributions.
Yeah, and let me address the whole issue of contribution. First of all, that's why we are sending our CHPs and our border people to assist, because I see a lot of a gap in terms of people understanding. If you have a husband, means tested, you don't need to have the wife means tested, because the wife is supposed to be the husband. The motto of SHA is what God has put together, let no SHA put asunder. Okay? So if the wife is, if the husband is already there, what is required is a connection between the husband and the wife, between the husband, the wife, and the children. And that is why, because a lot of people it's a challenge for them, that is why now we are taking the extra step of sending CHPs to do what we are calling assisted registration for the old people, even for the young people, because these things are not obvious. We need assistance, and we did that in Mombasa by sending our CHPs, and now in Nandi County we are expanding it to include the borders, because what may look obvious to some of us is not as obvious on the ground, and we realize that there is that gap of understanding, which we try now to do sensitization and to use our CHPs. That also is the same question that the student was asking. But let me address this whole issue of payment. To ask someone, and the governor is absolutely right, for some people, 600 shillings, 500 shillings per month may not be a lot of money. But for the bulk of our population, people are struggling, and we realize that. That is why in this Nandi County, we are privileged, because it's the first place where we are introducing Lipa Mdogo Mdogo kind of a program. We have worked with the mobile phone companies, mobile money companies, M-Pesa, and others to ensure that you can get deducted before you wake up in the morning. Pesa ya SHA ishalipwa.
Actually, somebody sent me a poster and asked me if this is what you really said. Can I read for you?
Yes.
Just give me one quick second. The question, nimepata. Government announces plans to deduct SHA directly from M-Pesa accounts of Kenyans who refuse to pay.
Not refuse to pay. Let me do something. Olive. You know, when Jesus walked on water, yeah, the newspapers in Galilee, they said, man tries to sink and fails. You know, they didn't see the magic of walking on water. The Kenyan media is like that, you know. We are not saying for people refusing to pay. We are saying people saying, me, I cannot afford. If you want to pay upfront, you pay. Someone will say, I don't know when the next time I'm going to be admitted at Kapsabet Hospital. Because I don't have an MOU with God, let me have some 20 shillings, 30 shillings deducted willingly. It's not about refusing. As a matter of fact, it's the opposite. It's people whom we have gotten to that step to assist them to have that process. Because ultimately, everybody must contribute to this national Harambee. Before this, I personally, I was contributing 1,700 per month. That was, I don't want people to follow me here, 0.17% of my salary. A driver who was maybe paid 10,000 shillings or 20,000 shillings was contributing the same amount of money. For them, that's a whole, 34% of their income. So the old system was discriminating against poor people because it was punishing them more. It was really too heavy on them.
But what do you say to those who say, I was paying less and accessing more services? For example, dental, has it even been rolled out? And then for a household, 1,000 bob.
I think PS will come to will come to the question of benefits and what he is doing, what the ministry is doing in terms of benefits. I just want to say that this issue, and the gentleman from KMPDU is right. This issue is about payments. We cannot afford NHIF out of the claims of around 4 billion, only 1 billion was getting paid. That is how all those debts were able to accumulate. We don't want to go back there. I went around yesterday in Nandi County asking people, when is the last time you heard of a medical Harambee? And all of them confirmed to me. They are not hearing about Harambees. Only yesterday, we increased our ICU HDU package from 4,000 to 28,000. Our oncology, cancer, 400,000 to 550,000. These are the benefits when all of us agree to pay that are going to accrue to
Because
members.
you've talked about benefits packages, right? You've introduced it. I'll ask you to weigh in, PS, because Wilson was also asking, where is he? I've lost track of him, but he was asking, oh, there he is. It's Wilson, yeah? Yeah, he was asking the question of what does it pay for? Is it the bed? What is it paying for?
Thank you. I think what I want to say here is, once you understand the benefit packages that are offered under SHA, then you really realize that you need to pay. Let me start by just saying, you've just raised the issue of dental, for example. You see, when you are doing the calculation, saying that if we are to offer service at this price, where every Kenyan is supposed to be covered, then you realize that we had to reduce some of our packages to cover at least a household. But what Senior Advisor Moses has said, we are reviewing these benefit packages according now to the needs, because we are getting data specifically and say, okay, fine, if we are able to increase this benefit package to this level, then we'll be able to cater for all those who are registered. So the issue that comes in, and what Dr. has said, it is a funding model. You are supposed to fund it through the Social Health Insurance Fund, your premiums that you pay. Once you pay and you are up to date, that means the collection has increased. We will be able to increase the benefit package. Right now, of course, we are not covering everything, but you will see that every year we review the benefits packages that we offer. As we are speaking, the first one has already been done. The second one, we are already now having a team that is going to collect data based on what we have already gathered from the treatment. How many people are going for dental? How many people are going for this kind of treatment? And then how do we then apportion that benefit? So it's a whole work that needs to be done, but what is key is what Dr. has said. We must fund this. We have, the funding model is two ways. Through the exchequer, that is of primary health care funds, and it is the total number of people registered times 900 shillings. That is what the exchequer will give to the various counties based on their registration. The other one is where all of us, based on our incomes, we pay religiously our premiums. That means the Social Health Insurance Fund will have adequate funds for us to cater for more benefits. All right? The referral system that you are talking about, it is important that we use the referral system, because if you don't use the referral system, we'll be burdening. If you ask the governor here, the kind of specialists that they employ at the referral hospital, Kapsabet here, are the ones that are specialized, and therefore they are need to handle special cases. Heart diseases, for example, issues of oncology, they have to go all the way. But screening should be done at level 2, level 3. And that's why we are saying we have to start our referral system. You see what's happening now is people are getting confused. They were used to going to Kapsabet. My brother, yes, said people know that if you go to Kapsabet, you will be treated and you'll, it's like that's the only place they know. But I think what is important is for us to continue engaging and creating awareness that there is no need for a patient to go to Kapsabet for minor ailments, yet he has left a Mosoriot level 3 hospital, which will provide the same treatment. And we have specialized healthcare providers there, either at the level of a doctor or a clinician or a nurse, who will be able to sort out those issues.
What do you say to what the governor had raised, the question of doing it progressively, because he was saying not all dispensaries are equal.
Agreed, and that's what we are working together with the county governments now. Number one is to support them on equipment, what's called the National Equipment Support Program to the counties. We want to support the counties to equip. They have done a marvelous job by developing the infrastructure. If you go across the country, in every county, you will see at least some structures for the health centers, for the dispensaries. We want to give congratulations to the governors. The issue now is equipping. If you look at their budget, they are getting, sometimes it will be spread too thin, and therefore, they have other needs. This Facility Improvement Fund was designed specifically, that act was designed specifically to ring fence now the money that goes into that facility. So you will see growth in those facilities. I can tell you, some of the, Pastor Elias here said, where I come from, I'm also a committee member of a faith-based facility. Right now, they are not struggling with the money. they are able now, in fact, they are starting to do the savings to buy some of those equipments that they were lacking. So the issue is funding.
Okay, all right. So still a couple of questions. One, what are you doing to net the informal sector, right? And then there was a question of the elderly and also the question of Linda Mama that was raised by Susan. So you'll take the question on informal?
Let me take the informal one. First of all, what saddens me about all these things is misinformation. And that is a problem of our media. And I think all the problems of this country are in Nairobi. Because today we had a wonderful session with our border people, with our CHPs. They are the ones who are asking, can you give us an easier mechanism for us to be able to pay according to our means? See, now somebody has already taken that and flipped it. Now, PS has talked about 900 shillings being sent. Not everybody who is registered in Nandi County will get sick. So this 900, for the people who get sick, becomes much more money. We have been calculating county by county, and every visit is coming to between 1,500 shillings to 2,000 that is covered for outpatient services. But back to the question of registration, that is why we are now sending our CHPs, we are sending our borders to actually assist these people, yeah? And we are giving them an incentive. Kuna kakitu kadogo kanakuja for them to do that, because, you know, we have to relate to, people have to, it has to be a joint effort from everyone. That misinformation I'm talking about is what also is frustrating registration, because our Leader Mama program, and PS, I would want you really to weigh in on this one. Our Leader Mama program is much better. The benefits are much better in TaifaCare than in NHIF. Not only is it much better, SHA is leading Mama, Baba, and Mtoto. Yeah? It's not just Leader Mama. Kuna Leader Baba, na kuna Leader Mtoto. In that. But now, it has been, you know, what has gone that, you know, we have dropped Linda Mama. No, we have actually enhanced the benefits of Linda Mama, and, you know, our
Susan is shaking her head no.
Yeah?
As we get a mic to Susan.
And I want you to ask the PS specific question of why you didn't.
Let's get a mic to Susan before we get, so PS, you'll answer Linda Mama and the elderly question.
The question that I was asking was about the version of Linda Mama in the TaifaCare. For example, at the moment, when we had the Linda Mama, we did not have to pay anything. Provided you are registered, you are able to get your antenatal profile for free. To us as service providers, we are feeling that there's a setback, that we had made some strides towards the improvement of maternal care. But now, because of SHA not providing that package that was being provided at that time, our clients are not coming to us because of the cost of the antenatal profile, meaning you will reach at the 9 month and the mother comes to you, probably if she's lucky to think of coming to a hospital and she's not been done any antenatal profile, she's not received any care or the package that involves the antenatal care. If a mother comes, probably who decides not to come, she will go to the mkunga at home, whereby we had improved on that, improving our skilled delivery to a better number, ensuring that our mothers are getting better care, and we're improving the quality of life, and we had improved on our maternal mortality rates and the perinatal mortality rates. So our questions still go back that, what is it that in TaifaCare has equally or even better package that is not going to take away or even probably deny our clients the services that we are getting? Another question that would come in, what is that we are doing about the anti-D, that a mother who is rhesus negative, she has to get 2 doses of anti-D. 1 dose of anti-D is 10,000 shillings. She's supposed to get it between 28 and 32 weeks. And then after delivery, she's not supposed to go home or not beyond 72 hours. You remember this is coming to 20,000 in 1 delivery. So the other question we'll ask, the SHA says you need to co-pay. They are going to give you anti-D for 5,000 shillings. Where is this mother going to get these 5,000 shillings for the first anti-D? The second one, again, before 72 hours that she goes home, there's the need of her to get 5,000, which SHA is paying, and the 5,000 that she needs to co-pay. Now, I'm left with women in my delivery room or even in the hospital that we're having more numbers that I do not even want to risk this mother going home because of her not getting the anti-D, because after that, And so immunization has taken place, the antibodies have been created, and there is no cry of a baby in another home. So for the sake of the women of this nation, our humble request is, can probably in policy level go back, redesign, and think in a special way, how are we going to take care of our women, how are we going to take care of our children? Thank you.
Or if I know she will not trust me, so
You know, I saw you scratching your head when she was talking about Auntie D.
No, because I want to invite Dr. Tracy John from SHA, because maybe a man cannot be trusted on this issue, to assist me in answering this question. She's sitting right there.
Before Tracy goes, I think, Susan, I want to say that maybe we as, together with you, the healthcare workers who ought to have understood the SHA benefit packages. And maybe the reason as to why we are even here is to now to engage with the public, to create awareness. Number one, Linda Mama program is still on. Currently in this budget, now listen, I'm the accounting officer. Currently, as you're speaking, what was allocated under the Linda Mama program is 2 billion. So we have the Linda Mama program. And I don't know whether you received messages or not. We've circulated this to all the facilities. Number one, that any mother who is pregnant and is supposed to go for the antenatal clinic should be accepted and registered under SHA if they are not registered. You simply, I think there is a code that we are registering under the Linda Mama program. We'll take care of you because of the pregnancy, because we have the money specifically for Linda Mama. And Linda Mama was about supporting pregnant mothers to deliver within the healthcare facilities. That should continue. So the issue is register that mother without even paying, they are entitled all through the antenatal and also pre. And I think that's what Tracy Jones will come and explain.
Dr. Tracy?
So I think the issue is not understanding. And what Moses has said is clear, that once you register the mother, then the mother will then onboard even the other children as dependents, including the husband. That's why now Moses says it is now the entire family. I think it is a messaging that you have not received. I want to welcome Tracy Jones just to give more details on in respect to that, but the benefit package. Linda Mama, before it was 5,000 flat, but now it is 10,000. And for cesarean section delivery, it is 32,000. So are you seeing the benefits? And on top of that, when there is any complication with that mother upon delivery, then SHA will definitely take over because they have become a contributor of SHA. We don't just pay this as for Linda Mama, we pay under SHA.
Okay, Dr. Tracy, as concisely as you can, please.
Thank you very much. I think, as the PS has already alluded to, the Linda Mama does exist, and it covers much wider benefits because before it was just the delivery and the baby and the mother that were covered for that period of time. But under the SHA program, then once the mother is registered and is paid for, then it's a full package under SHIF, which means that the entire family for the year can continue to enjoy the benefits, not just the baby, the mother, but also the rest of the family for the year. And as has been said, the tariffs are much better, the reimbursement amounts are much improved. I will not repeat on that. And additionally, even the issue of anti-D, where we have the mothers who are rhesus negative, anti-D has also been introduced in the benefit package, and it is covered. So the mother doesn't need to buy that. Additionally, also the primary health care services are still accessible to this mother because then they are entitled to the primary health care benefit as long as they are registered. So that puts the mother and the entire family under the entire cover that the SHA program is providing.
All right.
Thank
so
you.
You will forgive me, please. We now have to come to a close. Our time is up.
Minute, please. Because I don't want that question on maternal health care to go unanswered. Can you give 1 minute if she's satisfied? Because I don't
All
want,
right, that's fair.
I don't want the
That's
men
fair.
in this room to shun their responsibility and blame SHA for.
Women, and thank you for the information that you've given us. But there's the still part of the co-paying that is happening, and probably not me alone. I think we have one of our consultant with that, not consultant, our medical superintendent, who is able to give us what we've been doing exactly. Just with 1 minute, I'm sharing with him.
Okay, I'm Dr. Chepkwon, one of the medical superintendents in Nandi. We've said, to say more clearly, myself, I feel this issue of SHA is one of the best things to have happened to this country since 1963. But there are some few issues that needs to be sorted. Number one is the issue of cash flow. As a region, I don't want to say so much about Nandi. We are implementing several versions of SHA. I'm sorry I have to say that. Because of cash flow issues. Facilities have to run at the end of the day. So when we have delayed reimbursements, facilities have innovated. And that is not covered by the Act. I think that is why Susan is asking that question. But we'll do something about it, but we only need an assurance from this team that reimbursements flow. We will do a very good job. SHA is good, but again, if a patient comes and does not get services, quality services, it becomes a negative feedback, even hampering registration. Another issue is communication. We've really struggled with information on SHA from inception, but things are looking up. We are somewhere, we are proceeding well. Last part is around PHC. SHA should unpack the PHC reimbursement model. It will change a lot of these issues. Private sector, I'm sure they'll come on board. If the issue of PHC reimbursement is clear, what are the weights? Like, what is the global budget for Nandi the last month? What was available for those who registered? If I have a private clinic, I want to know, if I choose this person, what is the chance? What is the amount I may get? What is the status of registration in Nandi? I should be in a position to plan based on what I'm expecting. It will guide investments. Otherwise, overall, SHA is good. Kama kuna makosa tumefanya moja mbili, tutaenda kurekebisha nyumbani. Asante.
All right. And on that note, I will invite my panelists to make their closing remarks. We'll start with you, Moses Kuria.
I'm very pleased with this because the truth is coming out. Clearly, I don't blame my sister there and the gentleman. We have some work to do. And one of the things we want to do as part of actually this TaifaCare Express is that if I go to Mosoriot in a kiosk, I'll find something there called a price list telling me the price of mandazi is X. Yet, if I go to that facility, I cannot know the benefits which are covered. So we are going to roll out announcement in all our facilities. This is what is covered under Linda Mama. This is what is covered, so not just for the people in the facility, but also any patient who is going there can know what is eligible and what is not eligible. So the fact that we are here is the starting of that journey to be understood better. And I believe that actually, ultimately, once we do this together, we are going to have the best healthcare system in the world. In America, the healthcare system is private. In the UK, it's public. Kenya is the only country that is experimenting on a hybrid public-private model of financing health that does not discriminate. Ultimately, we'll get a Nobel Prize for this.
All right, Governor Sang.
For me, one of the things that is very important is that we are certain that SHA is far much better than the system that we had before. That is for sure. However, there are certain things that must be done within the shortest time. This whole rollout of the ICT solution that is supposed to support our health facilities to be able to do the claims needs to be sorted out. And I think if there is one thing that you must roll out, PS, give us the gadgets, do the training. I am sure that that consortium that was given the opportunity to do, or the task to do this, should be able to roll out across all the counties. Thirdly, we must also, as public institutions, one of the things that was raised by somebody here was that they prefer private than public. There is a history to that position. That the previous system used to give more preference to private institutions than public institutions. In terms of payment, for example, this Linda Mama program, C-section, we were getting 10,000, now we are getting 32,000. Previously, private facilities would actually claim up to even 100,000 for a C-section, which a public facility has been paid 10,000. That inequality between public and private led progressively to a situation where private facilities had more resources than public facilities, yet they were being funded from National Social Insurance Fund. We are very excited that this new system ensures that there is equality. And I am sure in another 2-3 years, that huge preference for private facilities might not exist, because all facilities across board will have resources that they can be able to offer services equally. You must deal with the major challenge of delayed payment of claims. The more you delay, the more the services deteriorate within the healthcare system, and we are not able to do that. The final point, again, you must deal with KEMSA. The refill rate within KEMSA must be sorted out, so that when we are able to make our orders for medical supplies, currently we are at about 60-something%. Why don't, 52 actually, why don't we push it and ensure that KEMSA have a refill rate of about 80-90%, because that is our major supplier for medical supplies. If we can be able to succeed to do that, I think the rollout is going to be smooth and successful.
Yes, are you sitting here thinking, hey, I can't wait Ishide Nyondoke?
I think I'm very happy that the issues that Governor Sang has raised are issues that the ministry is addressing. We've had engagements. We realize that the cash flows also, after KEMSA has supplied the drugs to the county governments, the cash flows back to KEMSA also takes time. However, we have to make sure that we overcome that challenge. Number one, we've recapitalized KEMSA. For example, in this supplementary budget, we have given additional 1.5 billion to support KEMSA to ensure that the order fill rate goes to 90% or over 90%. Two, we have also realized that KEMSA requires a facility, a credit facility. We have now agreed and approved for KEMSA to enter into an arrangement with a bank so that they are able to arrange a facility, credit facility, that should not delay, because of lack of cash flow, should not delay the supply of drugs. So all this has now been arranged, and we are going to give them facility, which is about 5 billion Kenya shillings, that will satisfy the counties. The only thing we are asking the counties also, as you receive the money, please pay back, pay KEMSA, so that you are able to get your drugs. Because this thing is like a machine, it has to rotate. If you don't rotate the money, then it will get stuck somewhere. So we are going to have a very close collaboration. I think the engagement with the Committee of Health of the COG has become very fruitful, and we are seeing results. Already with that, we expect that now that the money is going to the facility, then the facility should be the one to pay KEMSA. We might even ask that, sign an agreement so that SHA pays direct to KEMSA. It is a solution that we have. So we must all sit down, we must solve these problems. And I think I agree with the superintendent, the medical superintendent there. He says the problem is cash flows, because they are sometimes forced to say, no, lipa cash. That is the problem, because the facility requires money. What do you do with the patient who has come? And some of them, we have discovered, they refuse the SHA, the treatment under SHA, and says, he lipa cash, because they are in need of cash flows at that particular time. They need to buy gloves, they need to buy simple things. That is where the problem is. But healthcare service providers, please let us engage. Let us face this problem. We have all agreed here that SHA is better than NHIF. All right? So let's make SHA works. But I'm very happy, as I leave the ministry, I think 6 months delivering at that level please refer to America. It took them how long to stabilize the Obamacare? Delivering in just 6 months? To me, we need to give the Ministry of Health credit. And as I leave the ministry, please continue supporting this. I equate it to an aeroplane. It is not in the runoff, it is already takeoff. We are about to do what's called autopilot, because in a year's time, by 1st of October, we'll be doing an autopilot where every Kenyan will not be worried about their medical cover. This is something that they need to prioritize. The government has also prioritized. That's why, under the Abuja Declaration, the route the government has already taken is to make sure that we fund the primary health care fund. Care. You will see that going up, the rate of contribution from the 4%, it might go to that 15% or even surpass the 15%, because we have got to fund the primary health care. It is there now in the Constitution itself. Article 43.
I'm sure no Kenyan would argue with that. We all want the
Yes.
our healthcare systems to work, although on the 15%, there's argument, is it 15% of a chicken or an elephant? But that concludes our conversation, at least for this afternoon on TaifaCare. But it continues, because we will be back on Friday engaging Kenyans across the country on SHA, now TaifaCare, and their thoughts. Moses Kuria tells us they're a responsive government. We've learned a lot, Auntie D, and all of that today. I want to mjipigie makofi tafadhali. Thank you so much for your engagement, because this would not be a town hall if you are not here. So thank you for taking your time. Also want to thank my panelists, Moses Kuria, Senior Advisor, Economic Council of Advisors, Governor Stephen Sang, thank you for hosting this conversation, as well as PS Hari Kimtai. And that's it. My name is Olive Burrows. Keep it Citizen TV.